MfPH Next Generation Seminar Series is a networking event for early career scholars, junior modelers, and epidemiologists working on or interested in mathematical modeling of infectious diseases and other threats to public health. Bienvenue à tous, la série de séminaires MfPH Next Generation est un événement pour les chercheurs en début de carrière, les modélisateurs juniors, les épidémiologistes travaillants ou intéressés par la modélisation mathématique des maladies infectieuses et d'autres menaces pour la santé publique. First of all, we wish to acknowledge the stand on which the Fields Institute operates. For thousands of years, it has been the traditional land of Huron-Wendat, the Seneca, the Mississaugas of the Credit. Today, this meeting place is still the home to many indigenous people from across Churchill Island, and we are grateful to have the opportunity to work on this land. Premièrement, nous souhaitons reconnaître cette terre sur laquelle l'Institut Fields opère depuis des milliers d'années. C'est la terre traditionnelle des Huron-Wendat, des Sénèques, des Mississaugas. Aujourd'hui, ce lieu de rencontre abrite encore de nombreux peuples autochtones de toute Churchill Island et nous sommes reconnaissants d'avoir l'opportunité de travailler sur cette terre. Our guest today is a former Next Generation MfPH member, Dr. Zahra Mohammadi from University of Guelph and Memorial University of Newfoundland. She was a postdoctoral researcher at the Mathematics for Public Health program, the Fields Institute for Research in Mathematical Sciences, and she was research assistant in a computer algebra lab at Western University. Dr. Mohammadi holds a PhD from Western University, and she's working on modeling, simulating time series data, and predictive modeling. Notre invité aujourd'hui, Dr. Zahra Mohammadi, de l'Université de Guelph et l'Université mémoriale de Terre-Neuve, était chercheur postdoctoral au programme de mathématiques pour la santé publique à l'Institut Fields de recherche en sciences mathématiques et elle était adjointe de recherche au laboratoire de l'Université Western. Dr. Mohammadi est titulaire d'un doctorat à l'Université de Western et elle travaille sur la modélisation et simulation de données de séries chronologiques et la modélisation prédictive. Her talk today will be on pandemic decision support, importation models and travel restriction measures. Sa présentation aujourd'hui portera sur l'aide à la décision en cas de pandémie, modèle importation et mesures de restriction des voyages. Thank you very much for accepting our invitation, and Doctor, the floor is yours. Thank you very much.
Thank you. Good afternoon, everyone. At first, I want to thank you, use this opportunity, and thanks Idris and Zahra and Ben for providing this opportunity for younger researchers like me in this field to present our work. Today, I'm going to talk about my recent publication that's about the importation modeling, how to improve these importation models to guide policymaker in implementing travel restriction measure in future pandemic. And this work is supervised by Amy Harford from the Memorial University of Newfoundland and Monica Kojokaro from University of Guelph, and collaborated with the Julian Arino from University of Manitoba. After stating the problem and briefly introduction, I will explain about the data sources that we use in this work, and then I will continue talking about the importation models that we implemented and the variables we use for that. And I finish my presentation by some recommendation how we can improve this importation model for the future of the pandemic. And I will talk about the importance of some data sources and which type of data we have to collect it in the future. And at the end, I will be happy to answer any question if it comes up. And this work is published and is publicly available. It is published publicly available in medRxiv. And definitely, if you want to have more details about the method or the works, it's available. In January 2022, when the WHO announced the COVID-19 international pandemic, and they recommended countries to be prepared, But they didn't recommend any travel restriction explicitly. Although most of the countries, they implemented travel restriction and measures considered in the initial phase of the COVID-19. Later in about a year after that, in July 2021, WHO updating the recommendation, and they talk about some countries should consider the risk of the international travel related and consider some measures based on the curve of the COVID-19 in their countries and economic cost of that. Over the 2 years of the pandemic, we saw the variation of the restriction of the travel measures implemented between and within the countries due to the enormous of course, economic cost and also the lack of evidence that how these travel measures impact in controlling COVID-19. So this is the place that importation models can help the policymakers and assist them in health emergency, and in the different stage of the pandemic, and be able to detect the risk of importation or travel-related cases. Most of the variable in most of the importation modeling are arrival travel volume, infectious prevalence at the origin, departure, or destination of the traveling, temporal infection dynamic, vaccination coverage, border measures such as pre-arrival testing or quarantine. Most of the modeling, they included more or all of those variables to calculate the risk of imported cases daily or weekly basis. During the COVID-19, there was several studies such as the Sinazi, Wells, Hussein, and Russell work and etc. There is lots of them. They use the air traveler volume, infectious prevalence at the origin or destination, and also some other restriction to detect and calculate the risk of importation in China, in Canada, and other places. But most of those works, they use the air travelers, partial of the travel volume. They didn't consider the all or total arrival travel volume. And that leads to not accurately detect and calculate the importation cases. They overestimate or underestimated. And the result of that was they couldn't, this low quality of evidence for supporting the policymaker. And we saw the inconsistent implementation of the travel measures in different countries because most of the work didn't accurately detect the travel cases or imported cases. In this work, we focus to see what variable and level of the epidemiological details are needed to predict the risk of importation more accurately for the future, how we can improve this modeling, what variable is more important to consider. Among the Canadian provinces, Newfoundland and Labrador was the province that they set up lots of the measures from the earliest stage of COVID-19. For example, March 2020, immediately after the COVID pandemic start, they set up the measure 14-day self-isolation for all travelers entering to Newfoundland. They set up some restriction for non-resident travelers to enter the province from May 2020. They had a very strict test regime for rotational workers, and that started from September 2020. They had a lots of exposure notification that asked the traveler in a specific flight to go and do the test. So all of those measures that help them to be successful, at least in the origin, alpha, and delta variant of the COVID-19, and they nicely control the pandemic during this 3 wave, not Omicron, was different story. And Also, they asked the Newfoundland and Labrador, they set up one rule and they ask all travelers to submit the form that's called travel declaration form upon entry to the province that started from 2020, September 2020. And all air traveler or the land travelers, they have to submit this form and they inform the government why they enter in the province and the reason and the number. That's you can see in the left side of this graph. You can see I show them with the yellow for the Canadian provinces. That's aggregated of all Canadian in yellow color, and from international in gray color is the daily by dot, and the line it shows the monthly average. And also the other data that was available in the by the government of the Newfoundland and by the NUSHI data, that's I call it here NUSHI data, that's they reported the COVID cases, the infected cases in two categories. They categorize in the community case and travel-related cases. That in the plot B, that it shows the daily reported travel cases, not community cases. Travel cases from the Canadian provinces aggregated in yellow and the international in gray. If you can, I put these two figures beside of each other that you can see there is some correlation. When the number of the travel cases increase, the number of detected cases, travel-related cases or imported cases is increased too. So these two type of the data that was available in the Newfoundland was very great data sources that could be used for the importation model and see how we can improve the modeling by validating the data by these travel-related cases that was available in Newfoundland. So one of the variables for implementing and designing the importation model, as I've said before, was the travel volume. This travel declaration form can be used, but the problem here was there was a lots of exempt traveler to submitting this form. For example, the crew member was exempt to submit this form upon arrival, or the resident of the Newfoundland, they were exempt to submit this form. For estimating the total travel volume and find this exempt traveler, we use different data sources to find the total arrival travel volume to be used for the importation model. We use different data sources that I show in this table. Travel declaration form, that's in pink. I color it here because I wanted to use for the graph. That, as you can see, it's all mode of traveler, air, sea, land, but resident of the Newfoundland, crew member, they were exempt to submitting this form. The other source of the data that we had access to that, it was international air traveler. It just was air traveler, and the exempt part of that was crew member. And there was another very valuable data source that's publicly available is by Frontier Count by the federal government. They put in the Statistic Canada website, and they had the air, sea, land, all traveler enter to the country, and enter, you can kind of categorize that by enter the Newfoundland we consider. The problem is just for international. It doesn't have a Canadian. All the travelers coming from the other provinces to Canada, to the Newfoundland in this case. And we use some reported by the tourism department of the Newfoundland to find this correction factor for the missing value in each data sources that we need for some of them to consider the other mode of traveler or exempt traveler. That, as you can see in this figure, all of the data sources, you can see the blue line, dash line is the frontier count, just all mode of traveler from international. from March 2019 we had to May 2021, we consider, to see the effect of, also we can see the effect of this travel restriction on the reduction of the travel volume total. The gray line here, it shows the air traveler, AITI. We just had it before pandemic. And this pink one is just, we had the travel declaration form that just belonged to Newfoundland. They asked the traveler to submit that form upon arrival. And it has an exempt traveler. By using, as I mentioned, considered before in the previous slide, after using this correction factor, we will be able to estimate the total travel volume arrival in Newfoundland before and after pandemic that shows in a red line. Aggregation of the 9 months before pandemic and after pandemic, it shows 81% reduction. That's due to all the this travel restriction. This gray part in the middle, I have to mention, this gray part, we didn't have a data for this form as because this travel declaration form start from September. So we had in this gray area. So the travel restriction shows 81% reduction. That was agree with the report of the government of the Newfoundland that they announced 79% reduction, but it was just non-resident travel. This red line that shows the total arrival travel volume, we can classify that as a traveler who coming from the international origins or from the Canadian provinces. That in Canadian provinces in the yellow and international in gray. We consider the consistency of the color. And as you can see, the major of the traveler to Newfoundland was Canadian. We again zoom in these Canadian provinces, and we consider the rotational worker and regular traveler. But the interesting point that we notice in our study, just all of the travel restriction, it not just affected and changing the reduction, the total volume of the traveler, it also impact on the origin of the traveling too. In this figure, if we just look at the Canadian provinces, and that's the before pandemic average months, the same months in after pandemic and during the pandemic, you can see the number of the traveler coming from Quebec is decreased from 40% to 4%. But in the otherwise, the traveler coming from the Alberta is increased from 7% to 16%. This type of changes and reduction or increase in the number of travelers before and after pandemic, but in Alberta, from Alberta and Quebec, can be explained by the study that's by the HEVITI in 2018, that they mention high percentage of the rotational workers in Newfoundland that work in Alberta compared to Quebec is 57% compared to 2% from Quebec. And we all know during the pandemic, rotational worker continue to work, so continue to travel, but the regular traveler, they postpone, or there was some restriction, or so they postpone travel or cancel. So this kind of change can be explainable by this rotational workers volume. So after we, for developing and implementing our importation model, beside the arrival travel volume and as one of the variable, we consider infection prevalence at origin. Our origin was Canadian provinces and international. Also, we use the serology data for the coefficient as a coefficient to for underreporting cases. We consider some epidemiologic character of the COVID-19, such as probability of the developing symptoms, and probability of the true positive PCR test. From in this figure, we consider, we assume the distribution for the exposure between 0 to 13 days at the departure. And from the January 2021, there was a pre-departure PCR test that was required. From that date and after that, we consider 2 days before the travel date, we consider PCR test. And doing the test after arrival was varied for the regular traveler or for the rotational workers, because rotational workers, they were they had a very strict kind of the test regime. After sometimes 5 days, after 7 days, after 9 days, they have to do regular tests. So it detected, was able to detect these asymptomatic cases. And we consider 1 day delay in our model. So to predict the travel-related cases or imported cases in Newfoundland. In this figure, the yellow shows the imported cases from Canada as an aggregation of all provinces. And the gray, it shows the imported cases or travel-related cases from international. You can see some spike here in this figure that comes from the exposure notification. That's because in those exposure notification that the government or the health agency requests to people go and do the test in a specific flight, definitely more cases was detected. In this figure, you can see these detected travel cases from Canada that was classified with the rotational worker as a CARW and regular cases. The more portion of the travel related cases was belong this rotational workers, but because they follow the test regime and more detected. So this is our importation model and the result. And now is the time to validate the model and see which variable and level of the epidemiological details are needed to predict the travel-related cases. So as I mentioned in the previous figure, we shows that Newfoundland, they reported the data infected cases in 2 categories: travel-related cases, the people who had a travel history, and also community cases. So that data source can be used for evaluating the importation models. Beside this, our importation model that we call it EPI model because we consider the epidemiologic character of the COVID-19, we consider several statistical models where the parameter estimated from the validation data. In this table, you can see for Canada, we consider this variable of the explanatory variable. We consider travel volume, product infection prevalence. That's aggregated of the province or the whole Canada, province or the Canada. Infection prevalence separately, travel volume, and also for Canada and provinces. And we consider epidemiological model, our importation model that we saw the result. And for international, we consider travel volume, infection, product of both, and our EPI model result to compare and validate to see how much they can predict the reported data that was available. And we use the AKIOG information criteria to compare all the model to see which one was predict better. In this figure, you can see in the figure C, it shows Canada, and D, it shows international. The yellow color as a dot, it shows monthly reported cases, travel cases. And the green color, it shows the best model from this. The best model was travel volume times product infection prevalence of the provinces. And the blue one is our importation model that we call it epidemiological model here. As you can see, the best model here, the best model, that combination was able, explained 55% of the variance in daily travel related cases. And the kind of the poor prediction of our epidemiological model did well, except the last 2 months, April, May, because low data was reported here. For the international, we shows the gray dot shows the reported travel cases that we use for validation. The best model in green, and the blue color is our epidemiological model. Let's see what was the best model here. The best model for international was travel volume. But in this table, if you look at the international data in R square of that, you see none of our model was good, didn't very good. And the reason was because the lack of the availability of the serological data for most of the countries. We had we estimated the travel volume for each countries, but we didn't have access and for the estimating the infection rate in each country separately. So we aggregated the travel volume, and for this we just used the United States prevalence data and serology. So it's the reason none of them was good. But if we just consider the Canada and look at all of the model that we compare to each other, we notice for the improving the importation model, we should consider and formulate this model at a small spatial scale. When we consider the Canadian provinces separately, the model was better than when we consider the whole Canada. And also estimating model parameters from the data shows that when we consider less epidemiological character, the model was better. So just infection prevalence at the departure and the travel volume was able to predict better the travel related cases. So it means we need the high quality of these two. Just considering the portion of the travel volume, we cannot get the good result. And one of the key data sources that help us to validate our importation model and get the result was the data. Infected cases reported in Newfoundland was identified by community cases and travel cases. So it means all of the tests that request from the traveler should be publicly available and report travel-related cases for the future of the If we wanted to this type of data is not good just for validating the travel, the importation model. It's also good for the community outbreak study too. For example, in the most of the, when you wanna study the community outbreak, as we can different type of complemental model people consider, most of the researchers, most of the people are familiar with the SEIR type model, and there is some category some people consider as a travel cases. But if you don't have a different data as a travel case and community case, the result of your a study cannot be reliable. For example, if you look at this graph, it is for the Newfoundland. In the lower picture, the black color shows the reported cases, total combination of the community and travel cases. And the blue line is the result of the fitting. The fitting is perfect, but if you use this for the providing recommendation for the policymaker, the result is false. Because if you look at in the top picture, I put here the transmission rate of this fitting that calibrated as you can see, from May 2020 to February 2021, the number of the cases was so low, near zero, no community cases in Newfoundland, but the transmission rate was high. It's not explainable and it's not correct. So false result means unreliable recommendation. So even for not just for the importation modeling, for any community outbreak study, we need to consider to have a data split between consider travel-related cases and community cases. In the colloquium talk that's by Amy Harford, she mentioned how this type of data should be considered. This travel in this picture, that the dark pink is the travel cases in Newfoundland, and the light pink is the community cases, and the blue line is the fitting in this model. And for the doing this fitting, both type of data, travel cases and community consider, and this model that's known as a switch model, that it is ongoing project, and the people who attend in the colloquium that Amy Harford explained about this one with more details. And short story, just to improving importation model, that's important to use to collect for the future, to collect accurate data, and that's I mentioned. And I finish my wrap up my presentation with this famous sentences by George Box, that he mentioned all modeling are approximations, and they are wrong, but they are useful. If you wanted to provide the recommendation, reliable one, and assist the policymaker, you need to fit your model with the high quality data. And for importation model, this high quality data is collecting travel volume, the total incident cases. That's more important than considering the character of the epidemiological character of the disease. And also, if you're collecting the incident cases, it's better to be identified as a travel case and community cases. And thank you for listening, and I'm happy to answer questions.